Nuno Santos for the Institute of Medicina Molecular from Lisboa, who is going to talk about AFM as a technique.
Okay, thank you. Thank you for the opportunity to present here one of the lines of work that we have ongoing in the lab in Lisbon. And thank you for you all for staying for the last talk, extra time before going to lunch. And I will talk to you mostly about the interaction of fibrinogen, one of the main proteins that we have in our bloodstream with blood cells, and the relevance of this interaction for clinical prognosis. So fibrinogen is the protein that when we have a cut, a wound, it will polymerize, forming a fibrin network that will act as the scaffold for the formation of the blood clot in order for us not to bleed to death. And this process involves the binding of fibrinogen to its receptor in platelets, that it's the alpha-2b beta-3 integrin with its alpha and its beta subunit. And when we started working on this some years ago, the interaction was obviously already known. And it was also known that high plasma fibrinogen levels induce an increased erythrocyte aggregation, and that this increased aggregation was statistically, epidemiologically associated clinically to a higher cardiovascular risk. So this led us to study how does fibrinogen increase erythrocyte aggregation, if there is a specific receptor associated to this, or if it would be just an specific protein-lipid interaction, and of course also if we could somehow modulate the interaction to reduce hyperaggregation. And we did this mostly by atomic force microscopy, also by other techniques, but I will tell you just about AFM. And you are probably most used to see AFM being used to scan the surface of a sample to get a pseudo-three-dimensional high-resolution image of your sample. Of course, AFM can be used for this, but we can also use AFM taking advantage from its high sensitivity to get high-resolution images from the surface, not to get high-resolution images from the surface of a sample, but to measure interactions at the single molecule level. So in this case, what we do is that we covalently attach a protein, in this case fibrinogen, to the tip of the AFM, and then we go tapping on the surface of the cell, using the fibrinogen molecule as a bait to fish for its receptor, fish for interaction on the surface. So when we tap on the surface and the binding occur, we pull and we measure the force necessary to break the bond at the single molecule level. And so we can do this in buffer in close to physiological conditions in medium, and we do this with either the erythrocytes or the platelets just lightly attached to a polyalysine treated glass slide in order for them not to be floating around. And by performing these single molecule level measurements thousands of times, we can build up these histograms from which we can extract the typical force necessary to break the bond between fibrinogen and its receptor. In this case, on the first set of studies many years ago, we conducted in parallel studies with platelets that worked for us as a proof of concept and as a control to validate all our results. So with this, we could, by measuring the interaction in the presence and absence of calcium that is essential for the integrin receptors to work, doing the measurements with specific inhibitors from the different receptors, and doing measurements with samples from patients with Glanzmann thrombasthenia, that is an hereditary disease, a rare hereditary disease in which the receptor in platelets is either absent or present in a non-functional form. We could demonstrate the validity of the approach. Like if some of you is interested, we can I can tell about this in detail later on. And we could also identify that there is a specific receptor on erythrocytes for this interaction with fibrinogen that is an integrin, and we could identify, based on the studies with Glanzmann thrombocythemia patients, we could identify one of the subunits of the receptor, the beta subunit. The alpha subunit was identified by us in a paper 6 years later only, so we know that it's the alpha V or alpha 5 beta 3 integrin, the receptor of fibrinogen in these cells. But going to cardiovascular diseases, first of all, it's important to bear in mind that this is the main cause of death worldwide. If we consider even the projections for the increased of the casualties associated to cancer from the upcoming decades that are associated with the increased life expectancy, we can see that just putting ischemic heart disease and stroke together, they would be always way above the casualties associated to cancer. This is also a possible comparison in which you got here the deaths per year due to cardiovascular diseases, and we're comparing with the putting together of the values for malaria, HIV, AIDS, and TB, tuberculosis. So they are way above. Which cardiovascular diseases did we address? First of all, chronic heart failure, which can be divided into etiologies, ischemic and non-ischemic heart failure, in which the ischemic is the most common, is the one responding worst to treatment, and also the one with the worst prognosis. We addressed essential arterial hypertension patients, and also we are looking now, and this is an ongoing study, to patients with stroke patients on the ER service when they enter the ER service in the Santa Maria Hospital in Lisbon. And by measuring the same type of interaction on the AFM, so fibrinogen on the tip of the AFM, tapping on the surface of the erythrocyte, and measuring the force necessary to break the bond, we could see that heart failure patients need higher forces to break this interaction, and that this is mostly associated to the ischemic patients comparatively with the non-ischemic. But for our clinical collaborators, this was the most important finding. So we did the assessment of the patients at a given moment, at the beginning of the process, and then the clinicians made a 1-year follow-up of that patient. 1 year later, we came together again, and we compared the results, when we saw that the patients that needed the higher forces to break the fibrinogen erythrocyte interaction at the beginning of the study had a significantly higher probability of being hospitalized due to cardiovascular complications on the following year. And this points out to the value of this approach, not at the level of the clinical diagnosis, there are simpler methods to do it, but at the level of the clinical prognosis. So the pinpointing of the patients with a higher risk for cardiovascular complications that would need tailor-made and specific clinical approach during the following months or years. We looking at later on the results for hypertension patients, we saw the same pattern, so that increase of the force necessary to break the bond was not something exclusive for the chronic heart failure patients. It was also present on these patients. And for these patients, we did also the following. So we measured cell-cell interaction on the presence of different concentrations of fibrinogen. So in this case, instead of having a fibrinogen protein on the tip of the AFM, we use a tipless AFM cantilever using lectins to glue a cell to it, and then we press one cell against the other, and we measure not only the force, but the energy, the work necessary for cell-cell detachment. And we did this at the presence of different concentrations of fibrinogen. And the most important thing, the results are here in this plot, in which you can see that both for the patients and from the healthy control subjects, there is an increase on the work, on the energy necessary for cell-cell detachment upon the increasing of the amount of fibrinogen present on the sample. But you can see that patients start already from the beginning with higher values, higher energies necessary for cell-cell detachment. And so we could demonstrate at a lower scale that the fibrinogen molecule can transiently bridge these two erythrocytes and contributing for the increased cardiovascular risk. This is also partially associated to this gamma prime fibrinogen, that is a splicing variant of the fibrinogen molecule that has this additional length of 17 amino acid residues that gives it a stickier profile associated in some recent studies to a poorest cardiovascular outcome. And in fact, these patients had increased levels both of fibrinogen and of the gamma prime fibrinogen that we all have in our bloodstream, but some people have at highest levels, at higher levels that can result in a higher risk. For the stroke patients, we saw the same, and this is a study that is not finished yet. We still want to increase the number of enrolled patients. We could see this increase again on the force necessary for the detachment. We saw also this increased cell-cell adhesion even at low fibrinogen concentrations. And here we did also a new thing that was just poking with the tip of the AFM into the cells in order to evaluate its rigidity. And we could see that there is also increased rigidity and the lower penetration depth of the AFM tip on these cells, and this is also that can also be used for the assessment of the patients. Just a quick note on two other studies. In this case, we could in fact demonstrate that the different properties of this gamma prime fibrinogen, both at the level of the fibrinogen itself, but also at the level of the polymerized fibrinogen that becomes fibrin and the clots associated to this, because it's important that we have clots being formed as soon as we got a cut, but they also need to be degraded fast in order to avoid risks of thrombosis, for instance. And these clots made with gamma prime fibrinogen, they have lower diameter, but also they need more time to be lysed. So the fibrinolysis process is longer in time, and this can also contribute to the higher risk. And finally, we could also, in another study, using fibrinogen proteins mutated in different putative binding sites, we could identify the domains on the fibrinogen molecule that are associated with the binding. Let me just tell who really did the study. So Filomena Carvalho and Filipa Guedes did most of the experiments, also Marco Domingos, and Catarina Lopes is working at with the stroke patients and also with patients from other diseases, namely with ALS patients also. And I would like to thank to our collaborators, mainly the clinicians from the Santa Maria Hospital and the Polivalente Hospital in Lisbon, the funding, and you for your attention.
So thank you very much, Nuno, for this last and amazing talk. And we have time for the last questions of the session.
Hi, Nuno. Impressive work.
Thank you.
I have two questions. First is, are these all of these analyses made in live cells? And second question is, if they are live cells, how can you do the AFM acquisition? Because I know it takes time to do an image and to do all the characterization. How can you do it with a cell that needs to be in suspension and is not adherent?
Okay, so first of all, the adherence. That's why we use polyalysine treated glass slides, just to create an electrostatic interaction with the bottom surface of the erythrocyte in order for us to probe the top surface of the erythrocyte.
So you assume that there is no interaction or it doesn't influence the stiffness cells. Or you're assuming
we try, that? If there are some studies showing that, and this is not our studies, for the erythrocytes, if the adherence is too strong, that would allow for the loss of that biconcaval typical morphology of the erythrocytes, they will be stiffened by the interaction. However, if there is just that light attachment keeping the biconcaval morphology, there are no changes on the interaction. So some studies from a group from Montpellier that by other methods made that evaluation. Regarding the other question, well, these erythrocytes, they are quite stable, and it's not it's a cell without a nucleus. They can be using in smears for clinical assessment and so forth. So in this case, what we saw is that they kept the constant properties from the blood collection until at least 3 to 4 days. But we always study them in 24 hours.
Fresh samples, yeah.
Oh, yeah. It cannot be, if we do this with stored blood samples, like from a blood bank or something, the average of the results, it's similar, but the dispersion increases, so we just don't do it. So the patient enters the ER or comes to the regular appointment with his medical doctor, and they will do the routine analysis. They will just take a bit more of blood. We receive the blood sample on the same day, and we assess everything typically in 24 hours, if not less.
Thank you.
So, any other questions? I think it's time for lunch now. So thank you very much, Nuno. Let me thank again Nuno. And for sure, thanks all the speakers of this